Sujatha Sankaran. Completed medical school at USC and then residency at Georgetown, and has been on faculty here since 2011. She currently holds several roles as the Director of Quality within Neurosurgery and Medical Director of Smoking Cessation at UCSF, which is what she is here to talk about with us today. She's going to focus on several different things, including different evidence for different treatment modalities, different psychopharmacologic treatments, and other versions and ways we can help our patients in terms of smoking cessation. So you didn't come here to hear me speak, so why don't I go ahead and turn the floor over. Thank you very much.
Of course, thank you. So I am so happy to be here. I am a hospitalist, and so my primary clinical work is at Moffitt Long on the inpatient service and a variety of different services, but I'm also happy to do a lot of work with tobacco cessation and other quality and safety work. So to get started, I don't have anything to disclose. Objectives. So we're going to talk a little bit about the data behind effective strategies for tobacco cessation. I'm going to actually start out by giving you a little bit of context, both in terms of the global tobacco epidemic and then what our numbers are within California, and then what's actually happening here at UCSF. And then we'll talk a little bit about how to effectively screen for and provide counseling for tobacco cessation, so kind of clinical cessation strategies. And then we'll talk a little bit about the pharmacotherapy behind cessation. So just to start out with a case kind of introducing the topic. So Aldea Mills, a 37-year-old woman with a history of major depressive disorder, obesity, hypertension, admitted to LPPI after a suicide attempt. So you take her history, you find out that she smokes half a pack of cigarettes a day. Continue your history and you find that she doesn't drink alcohol, but does admit to using cocaine once a month, works as a cashier at a grocery store, and lives with her male partner and 2 kids. I mainly wanted to bring up a case because I think a lot of times when we see patients in a clinical setting, they're most often not here because of tobacco. They're here for a variety of other illnesses. And a lot of times the reason why it's a missed opportunity for tobacco cessation is because we're so busy focusing on everything else that's going on with them that the tobacco cessation piece just is missing. And a large part of that is I think a lot of times we think they have other things going on that are bigger. So we kind of brush aside tobacco because it's, the fact that she's snorting cocaine, if you sort of think about, all the other issues that she has, I think there's a tendency to say, okay, well, cigarettes, this is the least of her concerns right now. But I think if you look at the actual data, the number one cause of death in everybody still, in someone of this age group, still is cardiovascular disease. And tobacco is a major contributing factor. And there's a stronger link to, between tobacco and cardiovascular disease than any other risk factor that she has. So that's just to make a case that we should definitely, even though a lot of times we don't because we're focusing on other things, we should think about tobacco. Looking at the epidemic worldwide, I divided it up between women and men because I believe it's an interesting contrast. So you can see sort of worldwide in women, the rates of tobacco, and this is all forms of tobacco, is actually fairly low. In the United States, it hovers between 10 and 20% generally. Looking at men, it's much, much higher rates, especially in Eastern Europe and parts of Asia. In some regions, it's actually, if you look at chewing tobacco and smoking and sort of local forms of tobacco that's smoked in addition to manufactured cigarettes, it can be 80%. So very, very high rates. Looking at California, so this data ends in 2014, but it's fairly consistent. We hover around 15 to 20%, depending on what part of California we're talking about. And looking at San Francisco in particular, we're at about 10% prevalence of tobacco use. We can actually keep pretty good numbers at Moffitt Long Hospital, and the percentage of patients who use any kind of tobacco, not just smoke tobacco, is generally about 13 to 14%, so a little bit higher, which makes sense because you sort of think about the people who are admitted to the hospital, who tend to be a little bit sicker than the general population. That percentage is for people who are actively using tobacco. If you look at actually people who have ever used tobacco, that number shoots up to about 40%, and that's actually also pretty consistent. So looking at people who are hospitalized, a large percentage of them have smoked at some point in their life. So tobacco and UCSF, just to give you a little bit of a sense of everything that's going on. There's a lot of activities for tobacco cessation at UCSF. On the clinical side, at Moffitt Lawn, we have the inpatient tobacco cessation service. So what this is it's a service that consists of respiratory therapists who've been trained to provide smoking cessation counseling. What they do is every patient who comes in, they're screened initially by the nurses with the admission assessment. And as part of that screening, as part of the social history, there's a tab in Apex that basically says, do you use tobacco or not? If the patient screens positive on that initial nursing admission assessment, then that patient's name populates a list that directly goes to the respiratory therapist. So every day, the respiratory therapist team gets this list of patients who are actively using tobacco in the hospital. And there's actually one respiratory therapist who's the main smoking cessation therapist who sees all those patients on the list. It's usually about between 10 and 15 patients a day are seen. What they do on that visit is they talk to the patient about their use. And a lot of times you can imagine, people, these are not people who have agreed to quit or interested in quitting. These are just everybody in the hospital who uses tobacco. So you can imagine that there is a fair percentage of people who are not interested in receiving cessation. And that's been something that we've struggled with in terms of, does it make sense to actually try to touch every patient in the hospital with an intervention? What they usually do when they go in the room is they start the conversation by saying something like, UCSF is a smoke-free institution. We want to make you comfortable while you're here in the hospital. So we do have nicotine replacement available if that's something you're interested in. So that's often a kind of a nice way to open up the conversation because some patients are not interested in talking about this at all. So that's what the respiratory therapist does initially. They'll see all the patients, they'll provide them with motivational interviewing, and then they actually have 2 visits. On their second visit before the patient leaves the hospital, they'll offer them cessation resources. And the resources that we have available, and I don't know if everyone's even aware of these, but we have an outpatient treatment center called the Fontana Tobacco Treatment Center. So it's located at Mount Zion. It's a fantastic resource. They do groups. They have a physician who sees patients there as well. That's a resource that I hope everybody becomes aware of and uses. And so that's something that we offer. We offer them a referral to the Fontana Center. The second resource we offer is the California Smokers Helpline, which is 1-800-NO-BET+. So we give them information about that. So those are the 2 different resources we give them when they leave the hospital. So that's what's happening on the inpatient side at Moffitt Lawn. Fontana Tobacco Treatment Center I already mentioned. The other 2 centers at UCSF that are interesting and people should be aware of, one of them is the Center for Tobacco, it's actually supposed to be Tobacco Control Research and Education. So this is led by Stan Glantz over across the street, and it's a policy center. And they do a lot of work on policy. It's a world-renowned center. And their funding actually came from these tobacco papers, from the confidential documents from the tobacco companies that were released many years ago, and they actually were able to found the center based on that. So that's going on. And then the last one is the Smoking Cessation Leadership Center. So that's also a really prominent nationwide organization, and what they do is they primarily focus on providing materials for clinical cessation for clinicians. And so they have a ton of online information. You can actually download curricula if you're interested in training other people for smoking cessation. So a lot of information there. So switching now a little bit to talking about your patients in particular and what happens. I'm going to start out by just very briefly talking about some of the health effects of tobacco use. I think people are aware of this, but just as a reminder. So tobacco is linked to all kinds of cancer. So you can kind of look at every organ system. There's a lot of different types of cancer. Obviously, pulmonary diseases also are exacerbated by tobacco and caused by tobacco use. Cardiovascular disease, like everyone knows, is the #1 cause of death in this country and actually worldwide now. And tobacco has a large role in that. There's also reproductive effects. And I partly wanted to remind everyone of this because I think when you're talking to patients, this is a really important thing to keep in mind because these are, things that really affect people. When we were talking about how to do our inpatient clinical service over at Moffitt Lawn, one thing we talked about is who should we focus on? Are there special populations that we could focus on? And part of the reason is because tobacco cessation doesn't often follow this kind of changes of stage model people have an epiphany moment as opposed to kind of going through the stages of being pre-contemplative and then contemplative and so on. So one thing that really we've tried to do over there is we've worked on some of these patient populations. So patients who have heart disease, for example, has been an area that we've really focused on, really focusing on patients who are in the hospital because they have a disease that occurred because of their smoking. And that's such a good motivating factor. And there's actually data that supports that getting those patients at that moment can help prompt a kind of an epiphany moment. There's continue the health effects. There's also periodontal effects, or oral leukoplakia, oral cancers. So I think this slide is also kind of important to keep in mind when you're talking to patients about quitting. I think people who use tobacco imagine this really long and prolonged recovery time, and so it's important to kind of tell them that actually early, you'll probably feel bad initially, but you'll feel good pretty soon. So within 2 weeks to 3 months, circulation improves, walking becomes easier, lung function actually gets better. 1 to 9 months, you can tell people, that mucus that they're coughing up will actually get better. Some of their shortness of breath and fatigue and coughing will also get better. Within a year, their cardiovascular risk goes down to half of somebody who's continuing to smoke. Within 5 years, the risk of stroke goes down. And then within 10 years, it's hard to motivate people for 10 years out, but you can still mention that within 10 years, their rates of cancer actually will go down as well. And I always think it's a really nice thing to tell people that after 15 years, their cardiovascular disease risk will actually go back to the risk of somebody who has never smoked, because I think a lot of people don't know that. They assume that the damage that's done is permanent. So looking at mortality and kind of what happens, there's a study, so this is a male British doctor, so a very select population, unfortunately. About 35,000 were monitored between 1951 and 2001. And if you look at the mortality rates, so the number, this graph actually shows you the years of life gained. It's actually pretty significant. 10 years, if they stop at age 30, they could actually gain 10 years of life. And you can sort of see the numbers here. So it's pretty dramatic, the effect, and actually the direct effect on mortality that quitting helps people with. And I think, the numbers, you're obviously not going to sit with a patient and cite these exact numbers, but really driving home this idea that you're making a big difference in lengthening your life by quitting smoking is such an important thing to emphasize. And on average, cigarette smokers die 10 years younger than non-smokers. So I'm just going to be very quick with these, but the neurochemical effects of nicotine, just some of these things that just to remind you of why people like nicotine: appetite suppression, arousal, learning, memory enhancement, mood modulation, reduction of anxiety and tension, which is one of the big ones for people. So thinking about addiction, and I think I'm preaching to the choir here with this psychiatry group, but compulsive drug use without medical purpose in the face of negative consequences. So it's sort of just a formal definition of what addiction is. So nicotine withdrawal, you can sort of look at kind of the converse of everything that I talked about earlier. So irritability, frustration, anger, anxiety, difficulty concentrating, restlessness, feeling depressed, insomnia, impaired performance, increased appetite and weight gain, and then obviously these conditions. So one thing that I think is also important to keep in mind is a lot of these symptoms that people experience actually are worse in the first couple of days, and really that first 1 to 2 weeks is the really hard period for people. And then within 4 weeks, a lot of these symptoms subside. And this has been something that's been challenging for us on the inpatient side, because people are out of the hospital. That's sort of that period of time in which they're discharged from the hospital, and they're in the sort of the thick of these really bad symptoms. And what it's important to tell people is that really after 4 weeks, people end up feeling a lot better. And so when they're kind of in the middle of it, letting them know that can be helpful. So what contributes to tobacco use? There are a lot of different factors. The individual factors include maybe a genetic predisposition, their socio-demographic status, other medical conditions they might have. For example, anxiety obviously can can prompt people to smoke. The environment they're in is another piece of tobacco use, so advertising is huge. If you look actually at the interventions in this country that have had the biggest impact on decreasing tobacco use, a lot of it has to do with policy. It's had to do with decreasing advertising, decreasing availability of tobacco because of higher costs of tobacco. So a lot of it is actually environmentally mediated. And then social interaction. So when we're sort of thinking about the environment that a person is in for their tobacco use, their social interactions, who they're with, there are a lot of different influences in terms of are they going to use tobacco or not. And then the pharmacology of it. People use tobacco for weight control, for pleasure, mood modulation. And you'll talk to people very often. In fact, for me in my clinical cessation work, most people I talk to end up saying that they've tried to quit on their own, and they often end up self-medicating with using tobacco again because of to alleviate their own withdrawal symptoms. So all of these different factors together contribute to tobacco use. So really, when you think about how to deal with tobacco dependence, it's really, and interventions have to be focused on the physiological aspects as well as the behavioral aspects. So medications can help, medications for cessation can help that very physiological addiction to nicotine. And then at the same time, you need to deal with the habit of using tobacco with behavior change. And so it has to be both of them. And I'm not saying you have to use medications for cessation, but you have to address both of them and think about their addiction, their physiological addiction to nicotine in addition to dealing with their habit of using tobacco. So what can clinicians do? I think a lot of people are aware of this data, but you can see that if you compare patients who receive no assistance from a clinician, those who actually have assistance for quitting from a clinician are more likely to quit successfully. So you can see on the left there, no clinician, and then you add a little bit of self-help material and their rates of absence go up just a little bit. But if you have a non-physician clinician actually address cessation with them, you can see there's actually a pretty significant increase in the rates of cessation. And then there's data that shows that if a physician actually addresses tobacco cessation, that the rates of cessation are even higher. So again, making the argument to address tobacco with every patient you see. So the 5 A's, I don't know if people have heard of this approach, but basically ask, advise, assess, assist, and arrange. So we'll go through each of them. So ask about tobacco use. And I don't know how it is on the psych side. I know at Moffitt Long, we actually only have about 70 to 75% compliance with tobacco use, that being documented, tobacco use being documented. So as far as we know, only about 70 to 75% of people are being asked, do you use tobacco or not? There might be some problems with documentation, so that might be part of it, but at the very basic level, asking about tobacco use is extremely important. I suspect on the psych side, the rates might be higher in terms of asking, but I'm not sure. Advising tobacco users to quit, and I'll talk more in depth about how to do that and motivational interviewing and different techniques for advising. And then assessing for readiness to make a quit attempt is really important. So really understanding where people are at in the moment, and are they ready to quit or not, and tailoring what you do and how you intervene based on where they're at. And then assisting them in that moment with quitting, so things like nicotine replacement that we'll talk about. And then arranging follow-up. And I think this has been hard from an inpatient perspective in terms of kind of making sure that follow-up and that follow-through happens. But that's, and just speaking from that experience, that's a very vital step. We notice that our rates of cessation are driven completely by whether we're able to actually arrange follow-up. And that's why we're trying to really have people send patients to the Fontana Center. That's a great way to kind of follow up and make sure that they're continuing to be seen and they're being followed up on. Contacting the primary care doctor is also really important. It's something that we don't often do. And at the very least, having them, at least giving them the resource of the quit line can help as well. But just making sure that your acute intervention actually has some follow through and follow up is so important. So the decision to quit, so sort of talking about, you ask a patient if they're ready to quit, and then you sort of go on and talk about how, are they ready or not, and how do you assess that. and this question of how they can live without tobacco. So assessing readiness to quit. There's different stages that we talk about. Stage 1 is they're not ready to quit in the next month. Stage 2 is they are ready to quit in the next month, and this is the population that we focus most on, is this, the population of people who are ready to quit. Stage 3 are the recent quitters. They've quit within the past 6 months, and this population is really important not to let go of, and it's something that we're trying to train our respiratory therapists to do as well, is to really focus on. A lot of times if they, and the way our system works is that if they have quit, they don't actually screen positive, but actually making sure that you ask that question, and if it's only been 6 months, you continue to give them resources and make sure that they have outpatient resources to go to. And then former tobacco users who quit greater than 6 months ago is stage 4. So again, the population that we're really going to focus on is stage 2. So the stage 1 patient's not ready to quit. They're not thinking about quitting. So what is your goal with this patient population? If you're the clinician who's seeing somebody, you ask them, they say they're not ready to quit, they're not thinking about quitting. Again, I come back to this idea that people often need that epiphany moment, and it's hard to know when that's going to happen. And so your goal with this population is just to start that thought process, and you don't know when it's going to click and when they are going to be ready. So people, patients often struggle with ambivalence. Talking to them about what that ambivalence is about is important. And then just sort of planting the seed in their head that this might be something they would want to do in the future. The patient population that we're most focused on is that stage 2 ready to quit population. So these patients are aware of the need to and the benefits of, so they know they want to quit. They know that all the things that we've listed about the harmful effects of tobacco, and they want to change. And this is the population that I'm going to talk a little bit more about, and we're going to focus on. But the goal with this population is to have them achieve cessation. And I would add, that it's not on the slide, but I would add, and make sure that they have a follow-up arranged, that they have some way of that cessation be continued, and there's some health provider who's aware of it and following them. So the things to do with this patient population, so again, assess tobacco use history, discuss issues, and then facilitate quitting, and we'll talk again more about that. And this will involve both practical counseling and social support. So some of the key issues, so as this person screens positive, they want to quit, it's really important to delve a little bit deeper into why they want to quit. What are their motivations? What are their, a lot of times there's something specific, like, somebody's thinking about a pregnancy and they're interested in quitting before that. There's some motivating factor. So really understanding what their overall context is and why they want to quit is really important. Talking to them about their confidence in their ability to quit is important. Sort of thinking through, do they feel like this is something they can do? Have they tried in the past? And if so, what went well and what went badly? What happened? Why are they smoking again? So really delving into everything behind that. Understanding exactly what their tobacco use consists of is important as well. So what are the triggers for tobacco use? Is it that they wake up in the morning and they have a cigarette, or is it that they go out with a certain group of friends and they tend to use tobacco? So what is the situation? And really understanding that can help them plan how to avoid those situations. So what led to relapse in the past? And then people have, when you start talking to people about their tobacco use, they have different associations with it, and so understanding what those associations are really important. Are they doing it because they're stressed? Are they doing it because it's just part of a social pattern? Really understanding that is really important. So an idea, and I know in psych you guys get a lot more training with motivational interviewing, but the idea, as people know, is that you try to find positive motivation for quitting, for their tobacco use. So again, going back to that question of understanding what people's motivation is for quitting to begin with is a good start. So you really understand why do they want to quit, and you use the positive aspects of that to help them understand how they're going to quit. So if I let them the idea behind it is you really want to let them voice their reasons for quitting rather than telling them, tobacco is bad and it's going to cause all these harmful things. It's good to have that in the backdrop and to be able to answer questions around that. But really letting them tell you why they want to quit and why it's important for them, and having them sort of sit there and hear themselves say, I want to quit because of these reasons is really important. So things like asking permission to begin with. Is it okay if we talk about tobacco use? And this is dicey. I think there are a lot of patients who they've been taught, this is not a new topic for them. People have talked to them about tobacco a lot in the past. And I think a lot of times, like I mentioned earlier, we do tend to gloss over it in the face of other medical issues and other acute reasons why they're being seen, but really just kind of opening the door and having a moment of, okay, we've talked about all these other things that are going on with you. Now is it okay if we talk about tobacco use? And then eliciting and evoking change talk. So what would you like to see to change in your current situation? So why are you interested in quitting? What is it about your life you would like to change as it relates to tobacco? And if you decide that you are going to make this big change in your life, what would you have to do to make it happen? So rather than telling them this is what you have to do to make it happen, actually asking them, what do you think you need to do? And then if people are not ready, meeting people where they're at, just sort of saying, it sounds like maybe you're not ready right now to quit. What can we do in the meantime? Maybe we can set a quit date. Maybe we can think about what needs to change in your life in order for you to be able to quit. And then just normalizing it, and I think there's been actually increasing taboo with tobacco. I think that in substances, there are a lot of places obviously you can't smoke, and so there is a little bit of a taboo. So saying there are other people who still use tobacco, and it is hard to quit, and this is not unusual. So I'm going to skip the example for now. If we have time at the end, we can come back to it. It's just a little video of people of a good motivational interview. So stage 3. So we talked about stages 1 and 2, and stage 2 again is probably where we're going to focus most on. And then stage 3, people who have recently quit. What can you do to prevent relapse? I think the first thing is really to congratulate people and say, it's a big deal that you've quit. Congratulate their success. Encourage continued abstinence. So again, delving a little bit into understanding why they were using tobacco before is important, and talking to them about the benefits of quitting and whether what they've noticed the benefits of quitting are. What are the problems they've run into, and how they overcome. Sort of focusing on how they overcome any problems they've encountered, and talking to them about what their continuing barriers are. The other thing to really focus on is withdrawal symptoms at this stage. And a lot of times what that involves is really talking to people, and people will often say, I actually don't feel withdrawal anymore, because again, after that 4 weeks, often people don't feel really severe withdrawal. And so having them say that and realize that is really important. Promoting smoke-free environments. I mean, the environment is key, and I think both from a policy standpoint, but also just in that person's life, making sure that they're continuing to be in an environment where there's not tobacco use. And then again, I think the follow-up is really important, just scheduling additional follow-up. Just wanted to briefly talk about the brief encounter, because I think a lot of times we're busy and we don't have time for a lot of what I'm saying, these sort of detailed assessments. And in those situations, you can be very brief. You can just ask about their tobacco use, advise them to quit briefly, but then refer them to other resources where they're going to get more counseling and get more intensive services. And I bring that up because I think a lot of times we don't do anything because we feel like we can't do a good job with this. But there is data that actually a brief encounter can promote cessation. So actually even doing something as brief as just asking them and advising them and making sure they know about the Fontana Center or the quit line is better than nothing. So now I'm going to talk a little bit about specifics of methods for quitting. We talked about the non-pharmacological counseling and non-drug approaches, and then there's the pharmacological medications. So, and the data shows that both counseling and medications are the most effective. So that's just, it's important to think about both. So thinking about the non-pharmacological approaches again, I mean, there are formal cessation programs out there. So the Fontana Center is a good example of a place where you can send a patient to get those formal cessation programs. Again, at the Fontana Center, they do have individual programs in addition to group programs. There's telephone counseling. Again, the California Smokers Helpline. There is data that supports that the California Smokers Helpline in specific actually decreases rates of tobacco use. The study that I'm citing is pretty old. It's like 20 years ago, but that was using the same resource that exists now. There's also web-based counseling. There are some people who want to do it cold turkey, and I think if people are interested and enthusiastic about trying it, the data is not that good for cold turkey, but having said that, if people are interested, supporting them and letting them know that it's not a failure if they find that they're having trouble doing it that way, that you can still give them information about these resources that are out there. And then unassisted tapering, so this idea that people will slowly, on their own, extinguish their use of tobacco. So I'm going to talk a little bit about some of the pharmacological methods. So talking about nicotine replacement, there's a number of different forms of nicotine. There's the nicotine gum, and then there's a lozenge. There's the transdermal patch, there's a nasal spray, and there's an inhaler. So we'll talk about each of these and exactly how to prescribe them. So to start out with, what are the contraindications for nicotine replacement? The big one is patients with underlying cardiovascular disease. But I emphasize, I think a lot of times people get very nervous if they've had any cardiac history, and it's really just active, severe disease that we're worried about. So a recent MI in the past 2 weeks, a serious arrhythmia, or serious or worsening angina. So it's often patients who are, and in an inpatient setting, it's patients on the cardiac unit that we need to kind of select out who would be appropriate for nicotine replacement therapy. Most other patients are going to be okay, and any history of coronary disease is not a contraindication. So talking about specifically about the nicotine gum, so it's basically a gum with there's some resin complex, and it has this chewing gum base that people can chew. And it contains these buffering agents, and it basically helps the nicotine be absorbed from the buccal mucosa. There's 2 milligram and 4 milligram doses, and I'll talk about how you decide what to use. So the dosage is based on the time to the first cigarette. So you give people the 2 milligram gum if they smoke within, if they smoke within 30 minutes of waking up, you give them the higher dose, the 4 milligram. If they're able to wait more than 30 minutes before they use tobacco in the morning after waking up, then you can give them the lower dose. Does that make sense? So really the people who need tobacco first thing in the morning, you want to give them the higher dose. And the way you do it is, so the idea with the gum is it's really a kind of PRN type medication. So people use it when they feel symptoms, and so the way you administer it, it's basically in the first few weeks you give one piece every 1 to 2 hours. So you tell them, you can have one piece 1 to 2 hours. You obviously don't need to take it if you don't need it, but if you're feeling symptoms, you can use it. And then you slowly taper it off, and the way you taper it off is you increase the duration, so the frequency with which you give it. So in week 7 to 9, you tell them you can have a piece every 2 to 4 hours, and then you increase that to 4 to 8 hours. And often this works well, like a lot of medications. This is the sort of the short-acting PRN form of the medication, and it often works well with the longer-acting form of nicotine, like a nicotine patch. So somebody who's a heavy smoker, just giving them a piece of gum every 2 hours might not be enough, and you might need to actually have them on a nicotine patch, and then in addition to that, if they have symptoms, you can give them the gum as PRN. But it works differently for different people. The way they do it is you have them chew slowly, and they'll have this sort of peppery taste, and when that peppery taste is tasted, then you have them just kind of park the gum in their cheek, between their cheek and their gum. And then once that sort of tingling feeling fades, they can start chewing again. So it's sort of this release of nicotine from that gum. Some of the advantages, it's a good oral substitute for tobacco, so people who are used to chewing or having something in their mouth, it's something to engage their mouth with. It can delay weight gain because of the way it's absorbed. And again, like I kind of mentioned this earlier, but it can be titrated to manage withdrawal. So a lot of times, again, having that kind of long-acting medicine on board and then using it kind of as needed and then tapering it off is important. And then you can, like I said, you can use it in combination. Some of the problems with it, you need frequent dosing a lot of times. So one piece of gum every hour, every 2 hours is sometimes not enough for people. People who have dental work, it can be a problem. And then one other issue, which I found that there's a lot of varying comprehension of, is exactly how to chew it. Like even when you show people, a lot of times they get confused and not sure, should I keep chewing? Should I park? Where am I, am I doing this right? So that can be one problem. So nicotine patch is probably the form that most people are most acquainted with. It's well absorbed across the skin. And still delivered into the systemic circulation. I think one benefit of it is that the nicotine levels stay a little bit more constant, so it's not this constant up and down in terms of nicotine levels. The way you decide how much to give people is based on whether they're a light smoker or they're a heavy smoker. You can sort of see the 21 milligram patches are for the heavier smokers, and then 14 or 7 for the lighter smokers generally. So the way you give it, you choose an area of the skin, usually on the arm or the upper body. It's an area that's clean and dry, and then you want to apply a patch to a different area every day. So you want to sort of rotate the patch around, and then you try not to use the same area for a week. But that's just logistically what you do. And this is just a picture of it, so you kind of see it. People haven't used a patch or given patches for people before. So you press it firmly, you just put it on the skin, and just make sure that there's kind of a tight seal when you do that. So some of the advantages with the nicotine patch, it's once daily dosing, so that's a little bit easier than the gum that they keep needing to take. It's the least obvious in some ways, so they can just kind of cover it up and people don't know, and so sometimes that's an issue for people. You can use it in combination with other agents. So this, practically speaking, is the reason why I tend to use the patch a lot, is because, again, it's kind of, it delivers that constant level of nicotine, and you can use it as people need with other shorter acting agents. The one thing is with these acute withdrawal symptoms, you can't really titrate it. So that's one problem with the patch. They kind of just have to be on the patch for the day, whatever the dose is. And then if they have a lot of skin issues, obviously it's hard to use. I don't know if people have used a nasal spray. I don't see it used that much. We use it over at the hospital a bit, but not as frequently. So it's basically a spray bottle, and then it's basically these metered doses. And it gives a dose of nicotine with that, and there's about 100 doses per bottle, and then it's absorbed through the nasal mucosa. And each dose has 1 milligram of nicotine, and it's analogous to the gum in that it's 1 to 2 doses every hour until you kind of get to the maximum dose. And we say if in order to kind of keep the levels stable, usually it's about 8 doses a day, and people can then on their own taper down. I haven't, just anecdotally, patients don't seem to like it as much. I think people favor the gum a little bit more than the nasal spray. There's also a lozenge form. So this actually gives more nicotine in each dose than the gum. It's a sugar-free mint, and it's basically the same mechanism as the gum. And again, it's similar to the gum in that it's available in both the 2 and the 4 milligram dosages, and it's analogous again to the gum. It's every 1 to 2 hours they can take a lozenge. So some people just like this better than the gum, and then they can start tapering it off and increasing they're decreasing the frequency with which they're using it over a 12-week period. Usually 12 weeks is the tapering period that we use for nicotine replacement. And we tell them not to use more than 20 lozenges a day. And again, this, in my experience, it's a good kind of PRN med on top of something that gives more persistent levels. So now we can talk a little bit about the other agents, the oral agents. So there's bupropion. So the idea with this agent is that you want to again make sure that their plasma levels of the drug are achieved. So you want to kind of get to a consistent level. So what you actually tell people is that they actually want to start the treatment a week to 2 weeks prior to their quit date. So you want to make sure that you sort of set the stage for them to be successful when they quit. And the initial treatment is 150 milligrams every morning for 3 days, and then you go to a BID dosing. Again, all of these regimens, the idea is that this is the pharmacological piece. You're also at the same time doing the behavioral piece. And the program is really over 12 weeks. You're really trying to get people to quit over this period of 12 weeks. And you don't actually need to taper it off. This is going to be obviously an issue with the psychiatric population, but there is evidence, unfortunately, that there's an increased risk of suicide and neuropsychiatric symptoms, changes in mood, psychosis, so all these things that can suicidal ideation. So you sort of want to decide who you want to use this agent in. So Varenicline is the other one, and there have been studies that have looked at Varenicline versus bupropion, and Varenicline has showed that it's actually more successful in terms of cessation after that 12-week period is over, so more sustained cessation. The same idea in terms of you want to actually start therapy a week prior, you want to kind of get them stable, you want to make sure they're not having any side effects on the medication before you have them quit, rather than having everything happen at once. And then what you do on day 1 to 3 is you give them a 0.5 milligram a day, and then for the days 4 to 7, you give it to them twice a day. And then on day 8, you increase them to 1 milligram twice a day. And so at that period, again, you want that to coincide with all of your behavioral interventions. Make sure that they have resources from the behavioral standpoint at the same time, so they're doing everything at once. Again, there's these black box warnings, and there's changes in mood, depression. I've been in primary care as well for a number of years, and I've seen this a few times with Varenicline, so you want to be careful when you screen patients. And with the psych patient population, obviously you want to be very, very aware of some of these. Homicidal ideation, agitation, suicidal ideation attempts, and completed suicide. There are documented cases of completed suicide, so you just want to be very, very careful when you're sort of thinking through whether you want to actually put somebody on this medication. So the rates of cessation are excellent with Varenicline. However, it's only going to work for a certain subset of the population. So maybe before I sort of read the last slide, any questions about any of that, particularly the pharmacotherapy, since I know that was a lot of information? Yeah.
What is the standard dosage that someone gets from a cigarette of nicotine?
Well, that's a good question. I mean, it depends on, so from one cigarette, it's usually a milligram, they say. So it's the equivalent to about a milligram of nicotine. So, yeah.
Are any of the treatments contraindicated for patients who want to continue smoking marijuana in spite of wanting to quit nicotine?
So nicotine replacement is not contraindicated. With the medications, I don't think so, not that I'm aware of. Yeah, I'm not sure, 100%, I'll have to look into that, but definitely nicotine replacement is not contraindication. Yeah.
For bupropion and also for Chantix, just putting in their suicidal attempts as well as completed suicide, is that, especially for Lozenge, I'm more familiar with, but is that really the case? Because I don't think there's actually increased risk of attempts or actual completed suicide.
So for Varenicline, there is, I'm fairly certain, I can look into it more, but I'm fairly certain there have been.
The FDA rescinded that whole black box warning thing.
Yeah, but I think there have been cases of I know the black box warning has been taken off, but there were some cases still. So that's my understanding. I can look into it more, but yeah.
How do you generally advise pregnancy?
It's a good question. I mean, usually so people who are, so somebody who's coming in who's already pregnant is what you're asking. Yeah, you can give nicotine replacement to patients who are pregnant, and we often do advise that because you have to sort of assess how much they're smoking at the current time, but it's usually what's recommended is actually nicotine replacement, and you just do the same thing where over a 12-week period you try to get them off of it. So, but yeah, it's not contraindication. It's not a contraindication. I mean, the idea obviously is they're getting nicotine anyway when they use the tobacco, so.
Yeah. Are the things like the lozenges and the patches, are those covered by insurance?
So the patches are, I mean, it depends on the insurance, obviously, so the patches are covered. I don't know about lozenges, I don't know, it probably depends. I know that Medicare, you can get patches, actually, and even Medi-Cal, but I don't know if anyone knows about the lozenges. I mean, honestly, in clinical use, I haven't seen the lozenges used that much. I mean, we use them at the hospital sometimes if people don't want to use the gum, but I haven't given it a ton. Any other questions about the pharmacotherapy? Yeah, so just to conclude, I mean, I like this quote, so I always put this up here, but if we do not act decisively 100 years from now, our grandchildren and their children will look back and seriously question how people claiming to be committed to public health and social justice allowed the tobacco epidemic to unfold unchecked. And I think we often, again, I think it's something that is starting to become overlooked in clinical care, but it's still important to keep talking about. Thank you. We have a few more minutes if there's any other questions. Yeah.
I have a question. It's sort of maybe more of a philosophical question. And I know, we tend to think about other substance use disorders, for example, opiate use disorder, where someone might end up being on replacement therapy for the rest of their lives, buprenorphine or methadone. And with alcohol use disorder, we often sort of encourage people to have support around recovery, for example, 12-step programs. But it seems like there's a completely different focus in terms of addressing nicotine use or tobacco use. It's kind of like the goal is to quit, and then it's like the thing is in the past. And I'm just curious, I mean, there must obviously be data that supports that is the approach that's most successful. But just in terms of framing it in terms of an addiction, it just seems like a very different approach than the way we think about other addictions.
I think that's a fantastic question. I mean, I think in terms of what the recommendations are, there really are to get off of nicotine from a health perspective. So, I mean, it comes up every now and then, like how long do you leave people on nicotine replacement, right? Because there are people, we sort of arbitrarily kind of say 12 weeks is what we kind of recommend in terms of being able to kind of come off of a nicotine patch. And you have patients who get nicotine patches long after that. So what do you do with that? Do you continue them on nicotine patches as a long-term thing? It's generally not recommended. And I mean, and partly that's just because of the effects of the nicotine, like you don't really want to be on it long-term. But I think it's a great question, and I think our cessation rates, you know, again, like I said earlier, I think that the things that have made the most impact is just not making cigarettes as available, and from a kind of a structural standpoint. And from a kind of more of a personal biological standpoint, it's hard to get cessation. There's probably going to be some segment of the population that will continue to use tobacco. And so what do you do about that segment? Maybe it does make sense for them to be on nicotine long term. We don't talk about that a lot. That's not the way it's talked about. It's not sort of talked about in the same way as other addictions. I don't have a good answer for that, but it's an interesting point.
I mean, it sounds like presumably it's better to be on nicotine replacement long-term than smoking cigarettes or using tobacco, just because, you know, the difference between, I can't remember all the components of tobacco that drive the pathology, but in terms of, as opposed to just nicotine itself as a drug.
Yeah, and I think the question is, can you get people off of it, though? I mean, obviously it's best to get people off of it, so what is that curve? What does that look like? Is it impossible? You know, what percentage of people will never be able to come off of it? I don't know the answer to that. I think it's a good question, and I don't know if it's been studied in that way exactly.
Can I ask a question regarding risk reduction in terms of patients who say, well, I want to cut down my cigarettes, but I'm going to increase smoking my marijuana instead, or I'm going to vape instead? And do you have any thoughts about like how to counsel patients who say, I'm willing to cut back, but want to try something else instead?
Yeah, I left out e-cigarettes, which was I thought about adding because that's such a huge topic. You know, we generally, what's recommended and what I kind of agree with is that, you know, the data looking at e-cigarettes is that it's hard to know what the harm is from e-cigarettes by themselves. So there's this question of, does it make sense for people to be on e-cigarettes instead of the other forms of tobacco that they're using? And I think generally most public health people don't recommend it, right? And I guess I think part of it is this question of risk reduction. I think exactly the point that you're getting at. It's a sort of different philosophy. The way we've looked at tobacco cessation has really, we've looked at it as something that people can be, if given the right resources, the right tools, you can help people quit. I mean, I think that's been the goal, and it's been, if you look at the rates of tobacco cessation, of tobacco use and how they've come down dramatically in the past 50 years, it seems like we are actually doing a pretty good job, actually. I mean, we're down to, you know, 10%, which is pretty amazing. And so I think that's where this sort of idea that the goal is complete cessation and not, you know, using the harm reduction model. And so if you look at most public health agencies, they actually don't recommend e-cigarettes are sort of not widely recommended. If you talk to patients, many patients love e-cigarettes. I have had, you know, they are happy that they're using e-cigarettes instead of using tobacco, and that includes people who have, you know, been smoking for years and have tried to quit a number of times. So I'm reluctant to, you know, to have people switch to e-cigarettes, but I think you could make an argument for it.
And can I ask one more question regarding like marijuana and like, are the health risks the same for marijuana as nicotine in terms of like smoke inhalation and when counseling patients, like, do you think an all or nothing approach is best in terms of like don't smoke anything at all versus?
I don't think. I think that's a question of style. I don't think so. I think that their effects of tobacco in particular are much worse. There's inhalational effects with smoking marijuana as well. And again, I mean, it's this question. When I brought up that case in the beginning, the reason I brought that up is that, you know, this patient was using cocaine, what do you address? Do you address the tobacco and the cocaine? And my point is that you address everything. Having said that, I think there is a question of what, in a stepwise approach, I probably would start out with just addressing tobacco. But that's just totally a style issue clinically. I mean, I think different people obviously have different philosophies about that. But the harm of smoking tobacco is documented just much, much higher. There's just so much, again, still the #1 cause of death is cardiovascular disease. The link is strongest with tobacco, and I think really focusing on that's important.
I don't think any of the NRT items are considered drugs, but are generic yet, or are they? Or when they might become generic?
They are generic. I think there are, yeah.
They're generic.
Yeah, and they're available over the counter as well, which is good. I mean, it's just if people have a prescription, obviously they can be paid for by their insurance, so it's better financially for people. There's also, if you ever have, and I don't know how it works with language disorder, but I know if you have family members who use tobacco, we can actually get free nicotine patches for them. So if that ever comes up with people, you can page me. I mean, I don't know what the procedure would be for patients over here. I'd have to find out, but then we do that for patients often over.
Like during the hospital stay,
Yeah.
or rather
During the hospital stay. So if you have a family member.
extra.
That's right. Yeah, you can get nicotine replacement for them. All right, well, thank you.